So over the next few minutes, I just want to talk about prognostication. Just briefly recap of Mr. Diago. So now he has progressing dementia, and he may also have metastatic prostate cancer. And we know that now he has dysphagia, he has recurrent aspiration pneumonia, he's incontinent, he's poor appetite, he's having weight loss, and now he has more symptoms, and he's now getting more weak that he cannot get out of the wheelchair. So today I'm going to briefly talk about prognostications, what are the tools that we could use, and some common signs of poor prognosis. Prognostications is a tool that we as clinicians use it all the time. We use it to diagnose, we use it to start treatment, and also we use it to prognosticate. So a lot of time, we diagnose somebody with a chest infection. We tell the patient we're going to start you on antibiotics, and I think that you may be feeling better in a few days. So that's prognostication. However, when somebody hear about prognostications, that prognostic is something negative, so it's usually misunderstood and underappreciated. So why is it important to talk about prognostications? So for the patient and family perspective, there's a study looking at a PACE program in California that if the physician says that individual has less than 1 year of prognosis, then the family really wants 75% of the patient in that clinic wants to know. They want to be able to plan financially. They want to be able to spend time with their family as much as possible. And they want to use their prognostication to be able to make healthcare decisions. Should they undergo invasive procedure for something that is asymptomatic? So for the clinician standpoint, what do we use prognostication? So if we think that somebody has less than 6 months or less, then we want to think about, is my patient appropriate for hospice? Should I still continue the statin they've been taking all this while? If they have 2 or 3 years, then do I really need to make sure the blood pressure is 120 out of 80? Do I really want the sugar to be a hemoglobin A1C of 5? Or should I put them through invasive procedure for asymptomatic problem? Then if prognosis is longer, 5 to 7 years, then we start to think about, should we put our patient through cancer screening of colonoscopy, mammogram, or PSA testing? So we use prognostication all the time. However, one thing that we know is, as clinicians, we are usually poor prognosticator. We consistently overestimate. We know that if you have more experience, then it's better prognosticator than the less experience. We know that if you have a longer relationship with a patient, then you tend to be more optimistic. However, it also depends on prior experience. So I have to say that I've been practicing for so long now, I still is not a good prognosticator. I have told family that somebody has acute heart attack, that I say, I would not be surprised if your loved one passed away overnight. So they were sort of like shocked. But the patient ended up still with us for a few more days. So after that lesson, I tend to be more cautious if I'm too prognosticating prognosis. And then there's also a lot of new treatment that's out there. So for cancer treatment, there's a lot of new treatment, what we call immunotherapy, that we don't know how soon individual will respond to the treatment. And most of the time we rely a lot on testing. So we do a lot of X-rays and labs. All of them seems normal, but if you look at individual in front of us, obviously that individual is declining. So sometimes it's really hard to prognosticate. So this is a study from 1970 to 2000. If you look at estimated survival over actual survival, we always over-prognosticate by twice, 3 times, or even 5 times. So we over-prognosticate. So what are the tools out there that can help us? So I think in the case study, we talk about the surprise question. So we ask ourselves, would I be surprised if this person passed away in the next 6 months, which we use for hospice eligibility criteria? Or we ask ourselves, would I be surprised if this person died within the next 12 months, which we use as a trigger for palliative care referral for somebody that have life-limiting illness? And then this is a study done in 2017, which shows that this surprise question works well for patients with cancer. However, it's not too great for non-cancer patients. So dementia, COPD, heart failure. So it's not very sensitive and specific for that group of disease. So one of the other things that I like to use is called ePrognosis. If you put in the Google, ePrognosis will come up. ePrognosis is a database where they put in a lot of different studies that look at mortality for older adults. And then you will give you a sense, ask you a few questions about your patient, and it will give you a sense of what's the likely mortality for your patient. So there is a calculator that you look at prognosis of individual, inpatient, or at home. There's a cancer screening that I like because the cancer screening asks you a question about the individual, then you come out with a summary of what's the risk of doing colonoscopy, what's the benefits of doing colonoscopy, and then sort of risks and benefits. So it will input that. And then also I think it also has some video clips of how to prognosticate. So this is what you get. As you click on calculator, you will ask where is your patient at home, nursing home, hospital, or hospice. So we're going to do one on Mr. Diego. So he is in United States. I want to look at the 1-year prognosis. Does this patient has advanced cancer? Yes, he has prostate cancer. So if you click, then the database will refer you to palliative performance scale. What it looks at how functional the patient is, mostly sit and lie, activities, unable to do it, self-care, assist, oral, reduce, alertness, drowsy at times, the best case of median survival in days. So in the chat box, if you want to put in, what do you think that Diego's prognosis in days are? 22, 51, 115, or 221? We'll take 30 seconds for you to put that in. Becky, if you could keep track of making sure that I don't go overboard.
Will do.
Thank you. So we have 51, 22, 51, 51, 49, 90, 115, 51, 115, 22, 115, 51. Good. So let's just show that we, as clinicians, we are pro prognostication because, as you can see, there's a variety range of what we think. So after all that, this is the result that you get. So his PPS is 40%. So worst case scenario, 44 days, base case scenario, 60 days, but most likely 51. So this shows that somebody that have advanced cancer, certainly if you ask yourself, would I be surprised if Diego passed away within the next 6 months, then the answer will be no. Thank you. So I like the calculator, so you guys can play with it a little bit later, but all the calculator, if you look at it, the question that they ask is functional status. So the more function the person is, the better. Comorbidity, they will ask about any heart problem, lung problem, kidney problems, malignancy. So they will ask if somebody have any cancer. Nutrition status, they usually will ask what's the albumin of that individual. So the consistent theme that I come up using this calculator is they will ask about these four main factors. So are there any, because we cannot prognosticate clinically, are there any signs or symptoms that show that somebody has poor prognosis? So there are studies looking at signs and symptoms of dying. So some of us that has interact with patients in the hospital. So dyspnea is shortness of breath. So if somebody has really have trouble breathing, it's not a good sign. Individual may have pain. And also the other one is respiratory secretions, or we call it death rattle, because that's where somebody sounds really, really crackly on your chest. Delirium and confusion is a common one as well. And then dysphagia, weight loss, anorexia, and cognitive impairment. I think during this week, I get to ask about hunger all the time. Like somebody seems to have sign of dying, family will ask, would the individual have hunger? So my explanation to them is so all of us, when we get sick, we have lost appetite, we don't eat and drink. If you force yourself to eat and drink, you will just throw up. So we believe in our clinical practice that if somebody is at the end of their life, they're probably not going to eat and drink like a normal person. And then they probably would not feel the hunger that we do. If somebody is saying they are hungry, they want to eat, I think we will try to facilitate as much as possible.
2 minutes, Kim.
Thank you. So at the end of the day is we want to look at the whole pictures. We want to look at the individual. Clinically, they will tell us how the individual is, and actually listen to the patient. There is no signs, and I have no evidence to prove, but sometimes people just tell you that I feel like my time is short. And we have heard a lot of that. And then you will hear from families and caregivers saying that my loved ones has seen their deceased family member. That sometimes is also not a good sign. And also the trajectory is important. A rapidly declined, it's also a sign that somebody was able to walk and talk and independent, all of a sudden now they're bedbound. That's not a good sign. I think the symptoms that we look at is somebody that like to eat and drink. All of a sudden they're not eating and drinking. So that's a bad sign. So my wife says, if I'm sick, if I still eat and drink, then she thinks I'm okay. So somebody really need to be sick because people enjoy food. So the other thing is, recurrent hospitalization with infections, starting to have pressure ulcer, unable to think and do things on their own, and also in the context of all other complex medical problems. So I just want to highlight that prognostication is difficult. However, it's something that we do every day. And then I think combination of individual performance status, just symptoms, and now we have some tools can help. It is important that we start talking about it because it's important to plan ahead. Okay, thank you.